Good afternoon. Good afternoon, ladies and gentlemen. I'm Noriko Tomiyama from Osaka University in Japan, and I'm now AOSR president. Thank you so much for joining the Asian Ocean Society of Radiology, AOSR, and the International Society of Radiographers and Radiological Technologists, ISRRT webinar. Today's webinar is the third in the series of joint webinars about AsiaSafe. The theme is teamwork and collaboration is essential for radiological safety in diagnosis and therapy. I think we know this is important, but we don't know where about this in detail. Let's run together. Yeah. Professor NG, please proceed.
Good afternoon. Thank you very much, Professor Tomiyama, President of the AOSR. Welcome all to join this third of a series of a webinar. Let's show the slides and introduce the speakers. Yeah, as mentioned, we emphasize on teamwork and collaboration. As we know, in radiotherapy, radiation oncology, we have the teamwork, we have the radiographers or radiologic technologists, as well as the radiotherapists or radiation oncologists or clinical oncologists. This remind you that at the end of the two speakers, please post your questions in the chat box for panel discussion. We really want to devote more time for discussion. And also, please fill in the feedback form. A QR code will flash at the end of this webinar. And then there will also be a link in your chat box. Okay, and let's continue with the, we have Ms Chek Wee. She's from Singapore, the Vice President of ASIA-Australasia International Society of Radiographers and Radiological Technologists, the ISRRT. She served as Honorary Secretary from 1998 to 2002 as a President of the Singapore Society of Radiographers from 2010 to 2016, and then the ISRRT Regional Director for Asia from 2014 to 2022. She's a certified medical dosimetrist with the Medical Dosimetry Board in the United States, Master of Science in Radiotherapy Planning with Sheffield Hallam University in 2015. Basically, she is a very senior radiographers or radiation therapist. The other speaker is an oncologist from Indonesia, Professor Soehartati, fondly known as Professor Tati. He's the acting president of the IROS, Indonesian Radiation Oncology Society. She is also the senior consultant at the Department of Radiation Oncology, Universitas Indonesia, Cipto Mangunkusumo General Hospital, Jakarta. Actually, I met her many years ago there. So she started off with radiology training at the University of Indonesia and went on to do radiation oncology. So she's also have a PhD from the University of Indonesia, the UI. She has this award, Satya Lancana Karya, from the government of the Republic of Indonesia for her 30 years of service, the award given in 2019, and the Best Achievement Awards for Medical Workers, the Ministry of Health, Republic of Indonesia in 2022. Okay, now we would like to invite Professor Soehartati to begin this webinar this afternoon. Please, Prof. Tati.
Thank you very much. Allowed me to share my PowerPoint. Yeah. Can you see my PowerPoint? Yeah. Thank you very much. First of all, I would like to thanks to the, I'm sorry. First of all, I would like to thanks to the organizing committee of the AOSR, to Professor Tomiyama, and also thank you to Professor Hong for inviting me for this special event. Sorry, yeah. This is the topic that is given to me. I think it's a very important topic in the field of radiation oncology. And this is the outline of my talk for today. First, let's look at the very basic question in radiation safety. Is radiation good or bad? For a lot of people, when we talk about the radiation, especially heard something about nuclear, they will connect to the nuclear bomb accidents in the nuclear reactor. This is, of course, bad, but is it always really bad? It depends. Just like when we see the fire, it can burn house. It can also help us to cooking and lots of other stuffs. So radiation is good or bad depending on how we use it. Radiation can be utilized in various aspects to help humanity. It's truly beneficial in medicine, food, mining, industry, and so on. For example, radiation incorporated in the machine for food irradiator, it can extend shelf life, inhibit spot as disinfectant, and so on. Because radiation can be beneficial and can be harmful if it is not properly utilized. So the use of radiation needs to be regulated. And there is as we know, that international agency under the United Nations that responsible to regulate the use of the radiation for humanity, so-called the IEA. Now let's dive a little bit on the physical properties of radiation. Radiation is ionizing. You can see here, it's on the right side of the electromagnetic spectrum. Those that have very short wavelength and high frequency can ionize. Visible light is also a part of electromagnetic spectrum, but it's like some what in the middle of the spectrum, and it does not ionize. You can also see the utilization of all the electromagnetic spectrum they use here at the bottom of the diaphragm of the for the humanity. Radiation is generally not sensible to our human sense. It cannot be felt, cannot be smelled, cannot be seen. That's why we must be aware that be cautious of the radiation. We may not know is there any presence of around us. That's why radiation source must be properly labeled. In general, the further away from the radiation source, the less is the intensity of radiation by a square distance. The radiation can also be shielded by various materials. It depends on the type of irradiation. You can see here illustration in the right side of the picture. The more materials and the denser the materials between the radiation source and us, the less the intensity, because it has to pass through some sort of materials, and that process attenuates the radiation. It cannot be felt, cannot be smelled, cannot be seen. So safety issue become one of the most important factor to be aware. Radiation effect on the biological materials is long life, started from the physical, chemistry, biological reaction. So therapeutic ratio is become a very important factor when we give the radiation treatment. How to give a maximal effect of irradiation on the malignant tissue with keeping as low as possible impact in the normal area surrounding. Now let's focus on the use of radiation for medicine. Radiation has been used in medicine since more than decades ago. In 1895, this is the first time X-ray was discovered. That discovery led to the Nobel Prize in Physics. Later, in the following years, radioactive materials, uranium, radium was discovered, and this led to quantification of the radioactive decay. Since then, radiation has started to be used to help in diagnosing and even in the treating of the disease. What happened to the tissue after radiation exposure? The most lethal type of DNA damage is double-strand DNA damage. This kind of damage is more difficult to be repaired by cells. Even when cells can repair the double-strand break damage, there is high propensity that the repaired DNA is not proper, resulting in genomic instability and possibility later cellular death. Radiation will, of course, affect both cancer cells and surrounding normal tissue. However, there is a differential effect of cancer versus normal cell toward the radiation. This differential result in the therapeutic gain with the similar radiation dose exposed to cancer and normal cells. The response to the, as I mentioned before, the response of the cells that probably is higher in cancer cell than in normal cell, thus giving us a clinical benefit of radiation treatment. This is the evolution of radiotherapy equipment and technology over time. The modern radiotherapy now able to conform the dose to the target very well, just like a scalping of this statue, not just even movement, nor can also control during the radiation treatment. This graph also shows anatomical conformity with improvement in beam delivery. Today, we have MRT, VMAT, tomotherapy available also in our countries. In the near future, we hope that we can have MR-Linac proton therapy to better improve our ability in delivery radiotherapy in our cancer patient. This diagram is from the IEA roadmap toward a national cancer control program. We can see that radiotherapy is an essential element anyhow of a proper national cancer control program of any countries. The quote from the IEA report clearly indicates that radiotherapy saves lives and improve quality of lives. Thus, radiation is truly useful in medicine, and we need to advocate for greater radiotherapy installation for better cancer treatment. But of course, it needs to be safe too, with lots of QA and QC protocols in place. This shows you a clinical radiotherapy has lots of roles. It's useful in cancer treatment as definitive, adjuvant, palliative, and even benign disease. For example, here listed various indications of radiation and concurrent chemo as definitive treatment. Also, as in adjuvant setting after surgery, radiation has been fully beneficial for breast, endometrial, sarcoma, etc. Furthermore, lots of cancer patients in palliative setting with severe tumor pain, tumor bleeding, or even brain met needs radiation to alleviate their symptoms. And this has been proven to be a very effective, cost-efficient, and clinically beneficial. In benign conditions, some tumor that cannot be resected also need radiation to do the ablation. For example, in the arterial venous malformation can be successfully treated with high-dose stereotactic radiosurgery with a minimal side effect. Radiotherapy is truly essential in cancer treatment. Almost all the solid tumor will have benefit from radiotherapy. The indication list goes on, and as the technology develops even further, we have more precise radiotherapy. We can expect the indication list to grow. Today, radiotherapy indication has further expanded, not just as a local regional treatment, but potentially very beneficial and cost-effective for oligometastatic treatment. This paradigm started because of the capability of SBRT. Stereotactic body radiotherapy or ablative type of radiotherapy is becoming more prevalent, safer, and cheaper. Furthermore, SBRT can also trigger so-called the abscopal effect. This is the activation of our immune system, causing not target lesion to string to although clinical trials are still progressing. The evidence and role of radiotherapy in oligometastasis so far is very convincing. This technique mandates the presence of highly precise advanced radiotherapy equipment with well-trained personnel. this table, a study from Michael Barton and staff have shown that in average, 48.4% of cancer treatment will need radiotherapy along their cancer treatment journey, either as the curative, definitive, or adjuvant treatment, or even palliative treatment globally, so-called the optimal RTU, radiotherapy utilization rate. But we have our own RTU from our own data. From our ongoing studies showed that Indonesia has the optimal RTU of around 62.4% for 10 highest incidence of cancer in our country. And if it is extrapolated to all cancer, it becomes 56%. So it's higher than the number globally. So next we will talk about the overview on the process of in radiotherapy. The process to deliver radiotherapy is very complex. Maybe I'm sure that all of you know about this because most of us, I'm sure that we're working in the radiotherapy department. It started with CT planning using CT simulator. Patient need to be simulated and scanned in treatment position. This is used as the basic of tumor localization by radiation oncologists and also become the point of reference for patient positioning. And then next, the tumor and all the relevant organ at risk will be delineated by the radiation oncologist. After that, the radiation planning will be made by the medical physics. All this process will need a checkpoint to ensure that we work on each step is correct before proceeding the next step. Then, once the radiation plan being approved, the patient will start treatment. But before treatment started, the patient position must be verified. Depending on the type of machine, we can do the 2D or 3D or even 4D verification to ensure that our target is in correct position. Next, the treatment will commence, and this process of verification and treatment until plan radiation section is completed. As you can see here from the very beginning, the patient is taken care by the radiologist. Lots of process needs to take place. This is a very complex procedure and require multiple professionals working and collaboratively to successfully complete the radiation treatment safely. But we know that this also error prone. That's why the rigid safety mitigation strategy need to be in place and working properly. So patient safety has become one important priority to be done with the aim to protect a patient from the unexpected incidents. Steps that have to be done, for example, is risk assessment, identification, and risk assessment, reporting, and analyzing. Find a solution to reduce and minimize the possibility of the risk. Patient safety and radiation quality are two factors that close each other. Radiation quality talking about the accurate indication, target, dose, positioning, technique, tolerance, dose, and etc. And it can be achieved if we have a safety culture, including the behavior, human factors, leadership system, as well the environment as the environment. Now, furthermore, we will discuss on the risk of radiation accident in radiotherapy. It is shown that radiation accident can be occur in any step of radiation delivery, such as see here in the equipment. As an example, what happened in Canada and USA in 2085, software problem in Linux and Polandia. So all of this example is written in the book from the IEA about the radiation accidents. The maintenance also, mistake in repair and wrong information from the vendor in spines, for example, or calibration. And also there is an example for what happened As an example, what happened, radiation accident in USA and Costa Rica due to calibration mistake, and also treatment planning and use calculation and simulation, as well as treatment setup and delivery, as what happened in USA 2005 error and data transfer leading to MLC control point not delivered. That's all an example. In any step, radiation accident can be happen. This also shown various aspects that can lead to error during radiation treatments. Some common sources of error are tumor localization, lack of patient immobilization, field placement error in calibration, computational error, daily patient setup, or equipment-related problem. This paper, published in Red Journal after a comprehensive review of quality assurance program in a major radiation oncology center, the three most common errors are wrong patient or wrong site, incorrect setup or positioning, and incorrect data transfer or planning. With the complexity of radiotherapy process, a method is needed that can be used to ensure patient safety, because the slightest error that occur in one of the process will certainly affect the patient's safety. This is just an example what happened of a radiation accident that are noted in the book from the IEA about the radiation accident as learning material for all of us personals working in radiotherapy services. For example, what happened to 1995 in Costa Rica because of the miscalibration of cobalt. So this patient have something broken in the spinal cord, and also this in Poland 2001 because of the interlock failure of linear oscillator. And this also happened in the same, the patient have to be treated with the tongue cancer, and some miscalibration happen, and finally the patient becomes some condition like this. Quality control need to be carried out in various aspects, from the QA equipment, radiation machine, the patient radiation plan, until the software used to plan the radiation. All need to be done periodically and continually throughout the lifetime of the radiotherapy centers. So, if we have known the risk effect of radiation accident, we need to have prevention strategy. Now we will talk about what strategy. This publication mentioned that a safety culture can reduce the 47 of accident or incidents, which is the safety culture can be improved with the lean management or activities. And so it's risk management for operating radiation treatment should be, they said, similar as when people operate the airplane. So that's very detailed and something like zero failure. So this so-called the lean management in operating radiotherapy service can improve the high precision radiation treatment process. One method to reduce risk of accident is by multi-layer accident prevention method. Prevention is very important, and we have to aim at zero accidents, as I mentioned before. The ultimate aim of this method is to minimize the risk of injury to patient and ensure patient safety and the quality of radiation administered. There is actually an international standard for radiation safety, so-called the International Commission of Radiological Protection. The very basic fundamental principle of radiation protection as justification of a practice, optimization of protection, those limitations. This principle needs to be upheld in very strategy for prevention of radiation accident. This diagram show the process of QA/QC need to begin early, even starting when we plan for a radiotherapy center. From designing the building, it has to meet radiation safety standard. When constructing the building, also need to have a rigid assessment to ensure the building built as designed. Once completed, we need to test whether the building standard is proper or not. Then installation of the equipment commences before the operation. We will need to commission the radiation machine and ensure the machine work as it intended. Even after operational, we need a routine QA, QC of the machine maintenance and rigid standard operational procedures and audit process to ensure that we have continually ensured the proper safety standard. Once the radiotherapy center is operational, the method of multi-layer prevention can be implemented. The idea is that initiating event may occur repeatedly in daily practice or incidents. Without prevention layer, every initiating event may cause accidental exposure. The red block are the prevention strategy. By doing so, the possible accidental exposure can be reduced. But if we only have one layer of prevention, then when this prevention failed, accidental exposure can still happen. With multiple layer, basically multiple layer of independent prevention effort, greater probability of accidental exposure can be prevented. This is called as the defense in depth. You can see here the arrow where blocked by each layer. Thereby, with a multiple layer in place, we can block possible accidents completely. If the event happen, even it is blocked by the prevention strategy, this is still called as an incident and need to be reported and documented. This is a near miss event, but it does not result in accident. This is the point of making this multi-layer prevention a strategy. We don't want incidents to become an accidents. To access the robustness of our method, we need the data. The data is the incidents that were prevented in a period of time. This is not to find a fault, but to correct us and making sure tomorrow we work better and reducing the chance of having both accidents and incidents. So the basic of multi-layer preventions is involve physical and procedural component. Each layer must be independent. Routine check of these layers have to be performed as a part of care program. And the application of more than one single protective measure for a given safety objective, such that the objective is achieved even if one of the protective measures failed. This multi-layer prevention method combines several aspects that can improve quality of the radiation apart from the safety aspect. Here, the quality aspect is also highlighted. Quality in this case include the human resources and radiation equipment. This method mobilize all resources component in service. For example, internal parties, and also involve the independent expertise as the external parties. This is an example QA/QC process in my department. We have various independent auditing bodies to continually auditing us. We also have internal safety procedures starting from patient in clinic until the patient have received a treatment. We still do quality assurance process and patient round to ensure every aspect are correct. In machine sites, calibration daily, weekly, monthly, annually, and preventive maintenance are all carried out. This process is the culture of radiation safety. This is an example how the multi-layer prevention done in our department. For example, that's all for example, the morning meeting, that's we do it. And also we have the pre-quality controlled one. This is something like checklist. If it is not that check, so the process cannot be continued. The CT simulator also have to be checked. And the target volume definition is also have to be checked by the independent person, and as well as the treatment. And then the pre-quality control too, and the verification, treatment planning, and so as well as also the verification of the treatment. That's what we what we do so far. And this is another type of how we listed all the procedures that have to be done. For example, how to read it is the new patient in clinic. So this shown what have to be done, and then what we expect to have, and who will do it. So also the morning meeting, pre-quality controlled one, CT simulator, treatment planning, and continue to further process. And this just showed all the tech lists that we use. This, for example, for pre-QC1, and then let's continue how to match all the parameters, the beam, the check and have to be checked and approved by the medical physics, and RTT also verifying approved treatment plan, exported treatment plan on LINAC, and process of the clinical round in radiation oncology training program, also one of the check point that we have to follow. And for example, this treatment planning have also to be assigned by independent personnel, so not the person who make this planning, for example. And this is the business process diagram in our department, highlighting a more comprehensive process in all the quality and safety checkpoint. So this all the checkpoint that we have in the business plan, business process in our department. So again, patient safety is a top priority that must be implemented. The purpose of implementing patient safety in hospital, of course, to protect patient from unexpected event, as we mentioned before. Something that can be done to improve patient safety are the risk assessment, risk identification and management, incident reporting and analysis. And we need to continually find a solution to reduce and minimize the risk. And all the list, as I mentioned before, and the note has to be evaluated, calculated, reported, and compared with the standard value. This is the standard value. This is what we found in our daily practice. And yeah, this blue line is the result, and the red line is the standard level. And the quality assurance, quality control process of safety has to be integrated to the everyday practice, become a safety culture. So as a conclusion, radiation can be beneficial for humanity if properly utilized. Radiation for medicine has tremendous benefit from diagnosis until the cancer treatment. Radiation treatment for cancer is complex, involving many professionals. Risk of radiation accidents is high. An accident mitigation program has to be in place for all radiation oncology in all radiation oncology department. One strategy to mitigate radiation accidents is by implementing multi-layer filtering system with the redundant checkpoint. Radiation safety and quality is a priority. Thank you very much for your kind attention.
Thank you very much, Professor Soehartati Gondhowiardjo. Right. You highlighted the importance of safety through QC, and well, radiotherapy is a very complex process really of all the medical specialties. And the important part beside the radiation oncologist will be the radiographers or radiation therapists. So Ms Chek Wee will continue to show us how, explain to us the role played by the radiographers or radiation therapists, and see how we can work together with oncologists and medical physicists as a team, right? Because our webinar is on collaboration, teamwork. Ms. Tan, please.
So I'm not sure whether y'all can hear. You probably cannot hear my presentation unless you log on to the system.
Are you speaking live?
No, I'm not speaking live. It's recorded.
Okay. Who will play the recorded? Is it the?
Yeah, Rika is supposed to play the recording.
Okay, we wait for.
Hello, everyone. Today, I'm going to present on teamwork and collaboration for patient safety in radiotherapy. So before I start my presentation, excuse me, I would like to take this opportunity to thank Dr. Evelyn Ho and Prof Ng for giving me this opportunity to present at this webinar. So ISRRT will look forward to more collaboration with AsiaSafe to promote radiation safety in our region. So this is the content of my presentation. So as we know, radiation therapy is a highly effective cancer treatment that uses high energy X-rays or other particles to destroy cancer cells. It is a multi-stage process that utilizes technologies and professional expertise to work together to deliver radiation treatment to patients. So high level of accuracy is needed at every stage of the process to achieve the best care for our patient. Thus, each member of the team has the specific roles and responsibility in the treatment process, and teamwork is essential to ensure that everyone is working together for the safe and accurate delivery of radiation treatment. So as shown here, radiation treatment process consists of many stages, from the initial first consultation with the radiation oncologist to the pre-treatment preparation procedures and treatment planning to the final treatment delivery verification and monitoring process. So the radiation treatment process can be categorized into three main categories, that is the simulation, treatment planning, and treatment delivery and verification. And the main healthcare workers involved in the delivery of radiation treatments are the radiation oncologists, radiation therapists, and the medical physicists. And each of these disciplines will work closely together to ensure the safe and accurate treatment delivery for our patient. Thus, teamwork and collaboration among the different professional groups and even within the team members are very important in ensuring safe delivery of radiation treatment. I will briefly go through the three different treatment processes. So during simulation, based on the information provided by the radiation oncologist on the tumor location and the extent of the disease and the type of treatment required, radiation therapists will immobilize or set up patient in a specific position to ensure optimal treatment delivery, reproducibility, and minimal discomfort for patients during treatment. Images will be acquired during simulation and transferred to the treatment planning system. The setup position acquired from the simulation will be documented to use in the daily treatment setup reproducibility. And in treatment planning, the oncologist will identify the target volume and the surrounding organs at risk and decide on the most appropriate dose for treatment. Radiation therapists or dosimetry physicists will use the treatment planning system to devise the best treatment plan for patient and calculate the planned dose distribution based on the simulation images acquired. And the oncologist will review the plan and approve the plan, and physicists will perform QA checks on the plan to verify the treatment information, beam information. So as you can see from here, it is really a lot of team effort in order to produce an optimal treatment plan. And these treatment parameters will be documented in the patient chart or electronically downloaded or transferred to the patient management and verification system for the radiation therapies to deliver the radiation treatment. And during treatment delivery, radiation therapies are responsible for the positioning and the delivering of radiation dose to the patient as per prescribed and prepared on the treatment plan. Patients are positioned and immobilized so that they will be in the correct position for treatment during the course of radiotherapy. The treatment machine must also operate at a high level of mechanical and dosimetric accuracy and reliability every time for safe delivery of radiation beam. Thus, any incorrect positioning or poor mobilization, immobilization, or error in the treatment machine will result in the tumor not receiving the intended dose or greater risk of recurrence, or normal tissues are being treated beyond tolerance. Thus, there are risks in this multi-step and multidisciplinary process, and some of this error may be minor or catastrophic, causing serious injury to patient. So good teamwork is hence crucial in this multi-step process to ensure that patients receive safe, accurate, and high-quality care throughout the treatment process. Effective communication and collaboration among the different professionals are also essential for delivering the best possible outcome for patients undergoing radiotherapy. And according to the World Health Organization, WHO, on the widely reported major radiotherapy incidents from 1976 to 2007, apologies that information may be a bit dated, but this is the latest information available in WHO. So in this data, it reports that 3,125 patients were reported to be affected by radiotherapy incidents that led to adverse events, and about 1% of the affected patients died due to radiation overdose toxicity. And there were more than 4,500 near misses that were reported in the literature. And I would like to quote from Sir Liam Donaldson that radiotherapy is widely known to be one of the safest area of modern medicine. Yet for some, this essential treatment can bring harm, personal tragedy, and even death. Though major incidents are rare, however, the consequences can be extremely serious, as shown from a few high-profile incidents. So one of the incidents are the lethal overdose of Scott Jerome Park, a 41-year-old man in New York City undergoing radiation therapy for oropharyngeal cancer with curative intent. However, due to error in the planning system, he received fatal radiation overdose, resulting in death. So this is a pie chart from the WHO Major Incident Report from 1976 to 2007. So as you can see from here, the highest incidence of error is in the treatment planning stage at 55%, which is more than half, and 25% of error occur during the introduction of new system or machines, and 10% occur in treatment delivery, and 9% in information transfer, and 1% occur in multi-stages. And this slide shows the breakdown of errors in the radiotherapy process that major radiotherapy incidents occur that led to significant adverse events to patients. So the tables include the stage of the therapy that the error occur, the causes of error, and the recommended safety measures. So as you can see from here, there are quite a few incidents that are happening in the planning section. And at the safety measures recommendation, staff training and competency of staff to perform the procedures appear in many areas of the recommendation. So this has highlighted issues that lack of proper staff training and education of competent staff performing the procedures can increase the incidence of error in radiotherapy. So this is another slide that shows a major incident occurring from 1999 to 2007. And as you can see from these slides, over the years, regardless of countries and economic groups, planning stage still seems to be more prone to error. And in this risk profile document, an assessment of the extent of harm caused by radiotherapy internationally was also documented, since many countries may have experienced the same type of incidents over the years, and in response, an expert consensus group was convened by WHO to identify the inherent risk within the process of radiotherapy. Excuse me. And from the study of this incident and the factors underlying them, it has been possible to map the risk and to try to provide a solution. So the consensus group found that there are 48 risks in the radiation treatment process that were assessed to have potential to result in high impact adverse event, and the other 33 were estimated to have medium impact, and low impact were not considered. So these are the inherent risks in the different process. So under simulation, these are the inherent risks identified and the recommended solution. And in treatment planning, these are the inherent risks identified and the recommended solutions. So as you can see, the potential impact is high in many areas in planning, as any incorrect calibration or data input can affect a significant number if the error is not discovered, and the consequences can be severe, as it seems in previous incident report. And in the treatment delivery and verification, these are the inherent risks identified and the recommended solutions. As you can see across the three different areas, wrong identification of patients can have a serious impact if there are no system in place to verify patients' identification before the procedure. The establishment of the radiotherapy risk profile document has thus helped us to quantify the process of care in radiotherapy and systematically addresses the risk at each stage of the radiotherapy treatment. As in any system, errors are inevitable, and we need to understand why they occur so that checks can be put in place to minimize their frequency and maximize the detection before harm can be done. Some of the contributing factors that are of particular importance in radiotherapy incidents are staffing and skill level. So as was shown previously on the slide on radiotherapy process, that major radiotherapy incidents occur. One of the safety recommendations is on staff training. So given the complexity of modern radiotherapy, there must be adequate resources in place to train and equip the staff with the necessary skill and knowledge to perform the task safely and effectively. And next is fatigue and stress. So as we know, stress and fatigue can impact our cognitive function, which can lead to poor decision making or reduce our situation awareness and make it difficult for individuals to accurately perceive and respond to potential hazards or threats. So this can thus increase the likelihood of error, accidents, and injury. Next is the poor design and documentation of procedures. Poor design and documentation of procedures in radiotherapy can have significant impact on patient safety. So for example, if the setup procedures are not properly documented, it may lead to misinterpretation, leading to mistakes or inaccuracies in the treatment delivery. And next is the poor communication and lack of team working. Indeed, this is one of the most frequent causes of error in a number of radiotherapy incidents. Poor communication and lack of teamwork in radiotherapy can have serious consequences. as radiotherapy is a highly technical and precise treatment that requires coordination and communication among the different professionals. So if communications break down or there is a lack of teamwork, it can result in treatment errors that could harm the patient. Next is the over-reliance on the automated procedures. So it is important to recognize that automated system can go wrong. So without experience, it is difficult for us to recognize error, especially if the system has been safe and reliable in the past. And lastly is the work environment and structure. So error may also occur or may be triggered by factors such as poor design, room design, and treatment process. So the active engagement of the management is very important in operating a safe services to the patient. Hence, when establishing safety measures in radiation treatment, we need to learn from the past experiences and take into consideration the contributing factors in radiation incidents, the inherent risks, and work to improve on the safe delivery of radiotherapy. The key area identified in ensuring safe delivery of the radiotherapy are an adequate trained professional workforce practicing together in a multidisciplinary environment, strong operational and management system which can facilitate safe and for the staff to practice effectively, and equipment which is well maintained and designed with safety in mind. In conclusion, as patients undergoing radiation therapy will expect the best possible care with minimum risk and complication, it is important that organizations providing radiotherapy services need to ensure that there is a robust operational system in place with well-trained and competent staff working together in a multidisciplinary environment to deliver quality care to our patients. With that, I end my presentation, and these are my references, and thank you for your attention.
Thank you very much, Chek Wee, for the very concise presentation highlighting the importance of the process of your treatment planning and how to minimize accidents and incidents, right? And obviously, you have lots of experience in that, right? Singapore has one of the highest standard in the implementation of safety in the region, if not in the world. Okay, thank you. Now we have listened to our two speakers, Prof. Tati and Ms. Tan. We'd like to welcome you to send or post your questions. We have about 10-15 minutes to do that. Okay. Waiting, I'd like to start the first question. Now, what do you think is the move forward? We know it's a teamwork where the radiation oncologists working along with radiographers and medical physicists. So in what way could we strengthen the collaboration and move forward? Might be, I asked Prof. Tati to comment first and followed by you, Ms. Tan.
Yeah, I think we have to really work in a good collaboration. I mean, very close collaboration. For example, one important thing, as it is also mentioned by the next speakers, that the communication is become one of the big problem that the accident can be happen. Is that right? So how can we improve that communication? In my case, in our department, we have something like for the patient case, we have something like a morning meeting. In the morning meeting, all the personnel have to be there. So the medical physics, radiographers, the doctors have also to be there and discuss about the patient. So they will not, hopefully with this method, the possibility of a miscommunication can be reduced as much as possible. That's the first thing. in the daily practice. We have the morning meeting. We have also the what's so-called the Friday meeting. So after all the patients have to plan, so we have to have another meeting to set up how the treatment should be run based on all the planning and all those things that have to be done already. That's the first thing. And the second thing, we also have to be in the good team, and also we have to talk each other. For example, when we want to jump the technology, because once we want to, let's say, doing the, for example, so-called the let's say the SBRT or not whole body irradiation, it have to be discussed in the good way between the doctors, medical physics, and as well as the radiographers. So we cannot go jump the technology in only in one side, but not followed by the others. So I think that's the important that we have to be collaborate each other in a good way to avoid the possibility that there is a miscommunication how to treat the patient. That's my opinion. Thank you.
Thank you very much. Ms. Tan?
Yes, I do agree with Prof. Tati that communication is very important and how we can improve the communication between the team. So maybe team building activities where we can have the doctors, the physicists, and the radiation oncologists together to participate in activities together, and then so that they can understand each other better, and then hopefully to build, to break the barrier between the doctors, the physicists, and the radiation therapists, so that they are more willing to open up and communicate with each other if there are any issues. And then another thing that I think is very important is also the no blame culture. So I think whenever there's any incident or you think that something that you don't feel right, then at least you feel empowered to tell the doctors or the physicists to check, to double check. So I think that's quite important also, the no blame culture, in order to help us to work better and then to be able to prevent error.
Yeah.
Thank you. Can I
agree?
Yeah. Agree. Okay. Now, can I just proceed further? You mentioned about no blame culture. Well,
yes.
I started as a radiotherapy physicist long ago, 40 years ago. Now, in the Asian context, our culture is always put the blame on others. I wonder how is this been practiced in different countries in the Asian context? How do you fare, like say in Singapore? Do you manage that well?
So far for me, I'm very fortunate in my department. So maybe because our department is all very young, so the doctors are actually, so I think before we can have no blame culture, so understanding communication with each other is very important. So once you have the team building, you can break the barrier. And then whenever there's any incident happen, you do not put the name and all that. When you report incident, it's just you find out what's the cause, root cause analysis, and then how we can improve. So the person who is at fault will not be picked up or penalized. So it's just the process, how we can improve on the process. So maybe that can help if the person who is not being blamed. So maybe that can help to build up the culture. Or maybe, of course, we will need the oncologists or maybe the radiation physicists to help to lead the culture also. Yeah.
So I think we are, if I can jump in, we are trying to promote a radiation safety culture, right? So that the teamwork is automatic and not an effort, or there is no reluctance. And so we find that it is actually quite difficult, even with a no blame culture. How do you promote the radiation safety culture? As Professor Tati said, you can't smell it, you can't feel it. But at least in radiation therapy, you can see the effect quite soon after the accident happens, should a miscalculation occur. So is this radiation safety culture? I think it happens all over when we deal with radiation, ionizing radiation. It's not just in radiation therapy, it's same with radiology. Can you give us some tips, Professor Tati and Ms Tan? So maybe Professor Tati goes first.
Yeah. Okay. So yeah, we know that that's something that have to be done. The radiation safety culture, as I mentioned in my presentation, and what I shown you that there are a lot of checklist. Actually, is just to make it become a culture. Someday, somehow, maybe we can do it. Not all the patient have to. Not all the patient have to pass that checkpoint. If let's say from the checkpoint, it's already the safety culture, the finding of the incidents, as I mentioned in my presentation, is already very low. That maybe we can call that the safety culture is the radiation safety culture is already there. So we can, but still we can we have to do it continuously. Like in my department, actually we follow the ISO accreditation 6 monthly. With this kind of accreditation, we try to make the safety become a culture in our department. I think that in this time of period, since that we found that the number of incidents is already very low, that means maybe can say that we already ready as to have the safety culture in our department that implement all the QA/QC process in our daily practice. Yeah. But it's very, I mean, it takes time. It takes time. You know, how to make something become a culture. It takes time. We cannot hope that we can have it in a very short time. That's the reason why, as in my presentation, we have a lot of checklist. Just it's not because we are not trust people in our department that they don't do the safety culture, but just only to make sure that the patient will have good radiation procedures with safety radiation is done for all. Yeah, I think that's.
Thank you, Ms Tan.
So for me, I think that it's not easy. So like Dr. Ho has mentioned earlier. So, but I believe that we have to start somewhere. So because currently now it's maybe still very top down. So I would believe that maybe if the radiologists or the oncologists can take the lead and then get the radiation therapists and the physicists together to work as a team to start on small projects on maybe radiation protection, or how we can improve the culture, or how can we improve certain things that we are not happy with in a department. So maybe start with small project and then get everyone involved, even the nurses or maybe the PSA, so to get everyone to understand the problem first. And then maybe once you get a buy-in, then maybe it's easier to push through. So maybe that's what I feel. So probably get buy-in for everyone. And then someone has to take the lead and then get the project done. And then once the project is implemented, and then if you can see the results, then more people may be more willing to take the challenge or to try to change the process.
Thank you. By the way, we note that both of you are from the very top centers, right, in your respective countries. Obviously, there is very high standard, but those in the outlying hospitals may not be. I'd like to ask you all know about the saffron, right? The IEA saffron, right? The report. I was one who, the regional coordinator for that, trying, because it's very low reporting from our region, right? Obviously, no one can say there were 0 incidents, accidents. And one of the reasons is that the hospitals refused, right, to allow to be reported. That's why it is have to do with the governance and whatever our so-called Asians. So that is the reason that IA always is wondering what's happening, right? Why very few centers report in the saffron, right? This is our radiotherapy reporting system. Any comments or opinion on this?
So maybe for the saffron, so because our physicists are aware of this system, so so usually from what I remember, yeah, is that for saffron, usually we will report major incidents in the saffron system. So that was what I remember, that for saffron we usually report major incidents, but for small incident, like we will just generally report in our local hospital system. We may not be putting it inside the saffron. So it's only for major incidents.
Okay,
Yeah,
thank you.
so the major incidents that have already become an accident.
So
This
that
is
was my
incident.
question. Yeah.
What is the difference between incidents and accident? Incident is some daily failed in the setup as a standard, but what is accident? That means there is already an impact of that several. That's that's the reason why multi-layer prevention is done. I agree with you that the Ms. Tan, that what is reported by saffron is the major incidents. As we know that in the IEA, the case that I show you in my presentation is from the book from the radiation accident from the IEA that are reported, because it is already an accident and there is already an impact. But in my thought is we can say that zero incidents if we are not reported the incidents. So I mean the way the feeling that we have to report the incidents, that's a very important.
Yeah. Anyway, this saffron's voluntary. It is an incident reporting system, not to the
No, I
level.
mean, at least in the department level. In the department level, if we have such a kind of checklist, we know that, oh, that's not right. If we do some QA, QC, let's say in our center, for example, before 5 times we do the irradiation. The first time we do the irradiation, they have to be sampled. The QA is already done. That means sometimes we still found the incidents. That's from the report that we show you also in my presentation, but the standard level for the incidence is not more than 4%. That means our incidence is around below 1%, but still there are incidents reported, and it will increase the number of reported incidents if the no blame policy can be implemented in the right way. Yeah.
Okay. I think time is up soon. Thank you very much.
Any question, Prof. Ng? I have a
You
tiny
question. Okay,
Yeah,
please go ahead.
Yeah, because Ms. Tan said that we should not have over-reliance on automated procedures. I know what she means. But, you know, in AI is coming out, you know, ChatGPT has taken the world by storm. How do you see AI helping to reduce incidents? I'm not saying do your job or anything. How can it help to reduce incidents? That's something that we can look forward to, maybe. So Ms. Tan and then Professor Tati.
You first.
So in radiotherapy, the AI coming in is in the treatment planning part, so the automated planning and all that. So that's something quite exciting for us. Let's say if because currently the learning curve is quite steep. So once we have got the AI that can do the plan, so that means the moment the AI run the plan, probably around 80% is almost done already. So so in a way, of course, it's good for us, but it's just that if there's any error and all that, it may be quite difficult for us to know where and how to detect the error. So that's the only concern. So I guess, and then for us, we are actually not really equipped or trained in all the programming languages and all that. So maybe in the future, the training and education for the radiographer or maybe the radiologist, we need to have a big component in programming language to help us to understand the system better.
Yeah, for me, anyhow, we cannot trust 100% the even the artificial intelligence program is already there. The automatic, it can make our work maybe less, but we cannot. I mean, how to say? Anyhow, we have to check all the patient with our not just trust everything done by the system. Yeah, even the IA is already implemented in that area. Thank you.
Okay, thank you very much. I think with that is on the timely basis we conclude our webinar for this afternoon. Thank you very much for both speakers, Professor Soehartati Gondhowiardjo and Ms Tan Chek Wee, and also our participants. We noticed a lot of us here, a lot from Indonesia and other countries in the region. Thank you very much. And by the way, before you leave, please we'll show the QR code. Please help us. There's also a link in the chat box. Give us a feedback. Rita, can you? Yeah. Please take a snap of this QR code to send us your opinion, your feedback, and then you receive the certificates of attendance. Right? We're also planning the next webinar. This time will be on nuclear medicine. Right? We cover, because AsiaSafe covers diagnostic radiology, radiation oncology, radiotherapy, as well as nuclear medicine. So we'll announce that in due course. And thank you once again for all of you. And also time to wish our Muslim participants selamat berbuka puasa. I think very soon, right? About an hour's time, breakfast. So have a blessed evening and thank you very much. Bye-bye. Could the speakers stay on for a little while? We have some discussion.
So with your permission, can I conclude the session, sir?
Yes, please.
We thank Ms Chek Wee TAN ma'am and Professor Soehartati ma'am for their wonderful talk and all the delegates for being a part of this session. Special thanks to Dr. Noruki Tomiyama sir for this wonderful initiative and Emeritus Professor Kwan Hung NG sir and Dr. Evelyn Ho ma'am for organizing this session. On behalf of Vidoctor Project Management Team, this is Rekha and Sarita signing off, wishing you all a good evening. Sir, I'm stopping the live streaming, sir.